Welcome everyone. In today's video, we are going to talk about the anterolateral Watson-Jones approach to the hip joint. This approach provides excellent exposure of the femoral neck, head and acetabulum. It utilizes the intermuscular plane between the Tensor Fasciae Latae and the Gluteus Medius muscle. The extension of this approach requires partial or complete detachment of the abductor mechanism, which may be done through a trochanteric osteotomy or detachment of the anterior part of the gluteus medius and whole of gluteus minimus. Common procedures utilizing this approach are total hip arthroplasty, hemiarthroplasty, open reduction and internal fixation of femoral neck fractures, synovial biopsy of hip and biopsy of femoral neck. Now coming to the technique of this approach. The position is supine position with patient taken to the edge of the table so that the ipsilateral buttock hangs. The incision is an 8 to 15 centimeter anteriorly curved incision centered over the tip of the greater trochanter. This is superiorly directed towards the tubercle of the iliac crest, and inferiorly this crosses the posterior third of the greater trochanter before running along the shaft of the femur. Following this, the fascia lata is incised either over the femur or along the posterior margin of the greater trochanter. This split is extended proximally along the posterior border of the tensor fasciae lata and distally and slightly anteriorly to expose the vastus lateralis muscle. Following this, the interval between the TFL and the gluteus medius is identified. This is best done by finger dissection or blunt dissection. The TFL is retracted anteriorly and the gluteus medius is retracted posteriorly. The proximal extension of this dissection is limited by the superior gluteal nerves and vessels. We may encounter perforating vessels in this interval which may cause bleeding, and these have to be identified, ligated or coagulated. Following this, we have to place the retractors. The first retractor is placed between the gluteus medius muscle and the upper part of the femoral neck. Additional retractors are placed inferior to the neck and towards the acetabular rim. Here we can see the superior gluteal nerve, which forms the proximal limit of this dissection between TFL and gluteus medius. Now these retractors, once placed, they properly expose the anterior joint capsule. External rotation of the limb further improves the exposure of the hip capsule. This is followed by release of the anterior part of the vastus lateralis to expose the inferior part of the anterior capsule. If a wider exposure is desired, a trochanteric osteotomy may be performed or the insertion anterior fibers of the gluteus medius may need to be released. Also, the origin of the rectus femoris may need to be released if a wider exposure is required. This is followed by a T-shaped capsulotomy and dislocation of the hip by external rotation. Following this, the procedure can be performed and the capsule is repaired. Now let us see the dangers or the structures at risk during this approach. The nerve at risk is the femoral nerve, which is the most laterally placed neurovascular structure in the femoral triangle. This is prone to compression neuropraxia by excessive retraction of medial structures or retractors placed on the surface of iliopsoas. So we have to be careful that excessive retraction of the medial structures is avoided and the retractors are directly placed over the bone and not over the iliopsoas. Now coming to the vessels at risk. The first vessels are femoral artery and vein. This is again at risk due to incorrectly placed acetabular retractor over the surface of iliopsoas, which may pierce these vessels as these vessels pass over the surface of the muscle. So, the method to prevent injury is to place the retractors directly over the bone with no intervening soft tissue. Putting the hip in 30° of flexion often helps in finding the plane between the rectus femoris and the anterior part of the hip capsule. The acetabular retractors should be placed at 1 o'clock position in the right hip and at 11 o'clock position in the left hip. Another method to prevent injury is placing the acetabular retractor directly after the capsulotomy. The other vessel that may be at risk is the profunda femoris artery. This lies over the psoas muscle deep to the femoral artery. An anatomic variant may lie close to the anterior acetabular rim. So again, this may be injured by inappropriately placed retractors, and we have to follow the same precautions and place the retractor directly over the bone and be on the lookout for any anatomic variant which is lying close to the anterior acetabular rim. So friends, in this video we discussed the anterolateral Watson-Jones approach to the hip joint. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.